Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/TPE. This activity is supported by an educational grant from Decifera Pharmaceuticals. This educational content is intended for Europe-based physicians only.
Hello, my name is Michiel van der Zande from the Medical Center in Leiden in the Netherlands. Welcome to this educational program on tenosynovial giant cell tumors. I'm very pleased to have Silvia Stacchiotti from the Istituto Nazionale Tumori in Milan, Italy, joining me today.
Thank you, Michael. It's a great pleasure to be here with you today.
In today's discussion, we'll explore how recent advances in systemic therapy are reshaping the management of tenosynovial giant cell tumors and their implications for surgical decision-making. Tenosynovial giant cell tumor is a rare and locally aggressive neoplasm of the joints, bursae, and tendon sheaths. It's mainly diagnosed between the age of 20 and 40, and importantly, despite being non-malignant, tenosynovial giant cell tumors have a profound impact on patients' physical functioning and quality of life. Recurrent swellings, pain, and progressive joint damage can significantly limit mobility and daily activities. We acknowledge there is a localized and diffuse type of tenosynovial giant cell tumors. The nodular type is mostly in smaller joints and easily resectable. The recurrence rates are reported less than 15%. Diffuse disease is more difficult to treat. It mostly affects larger joints, has more aggressive, more complaints, and a very high recurrence rate after surgical resection. Generally, active surveillance is the first step in treatment, followed by surgical resection, and if not resectable, systemic therapy is a very good option. Experts' consensus do not recommend radiotherapy as a treatment for tenosynovial giant cell tumors. When we consider different types of treatment, we have to acknowledge localized or diffuse disease, the amount of symptoms, and patient preference. Zooming into surgery, which is still the most common treatment of diffuse type tenosynovial giant cell tumors, recurrence rates are and remain significant, highlighting the need for alternative strategies as shown in these graphs. Primary patients may benefit from surgery, but recurrent patients mostly recur. If we look at the type of surgery, there's not a big difference between open or arthroscopic surgery, but new treatment strategies are needed. Silvia, could you walk us through the clinical evidence for approved and emerging systemic therapies in tenosynovial giant cell tumors?
Yes, thank you for sure. TGCT is characterized by the presence of MCSF1R alteration. And over the last year, we saw the development of drugs able to target directly this mechanism. All these drugs were investigated into phase 3 randomized studies versus placebo, with overall response rate at week 25 as the main endpoint, and the chance of patient being crossover after week 25, PROs as complementary endpoints, and the patient population being TGCT patient, adult, with the evidence of symptomatic and locally advanced unresectable disease. The first drug to be studied was pexidartinib in the ENLIVEN study that proved the activity of the drug with an overall response rate of 39% at week 25. The disease control was prolonged, but unfortunately the drug showed a risk of severe life-threatening hepatotoxicity. This prevented the approval of pexidartinib in Europe, while the drug was approved by FDA within a risk evaluation and mitigation strategy plan. The second drug, vinceltinib, is a selective switch pocket tyrosine kinase inhibitor investigated into the MOTION study Again, the study showed the activity of vimseltinib, an oral compound administered twice per week, with an overall response rate of 40% at week 25. All quality of life assessments were consistent. The disease control was prolonged, and luckily no severe hepatotoxicity was observed. And on this basis, the drug is now approved for treatment by both the FDA and the EMA. The third drug, pimicotinib, was investigated in the maneuver study, again a randomized versus placebo, where the drug administered orally every day showed activity, 54% at week 25, confirmed at a longer follow-up, with all PROs and quality of life assessment consistent with the radiologic response. Even in this case, no severe hepatotoxicity was observed, and on this basis, the drug is now approved in China. Finally, we have an monoclonal antibody, emactuzumab, injectable, administered for a limited number of injection, followed by follow-up. This compound was investigated also in pediatric patient within a study with the same endpoint, and is currently results are currently awaited. This said, Michael, we have some question to answer, right?
Definitely, especially for the surgical community, it's important to understand what elevated CPK levels mean for patients. So can you tell us a little bit what happens with CPK and CSF1 inhibitors and how we should interpret and manage this?
So CPK elevation is a very common event in patients treated with MCSFR1R inhibitors, and sometimes it can reach also grade 3, grade 4. However, it is not related to the presence of cardiac toxicity, neither to the presence of rhabdomyolysis. Therefore, for what we know so far, it should not be a cause for concern. It is reversible upon discontinuation of treatment. Probably we should take into consideration this alteration for patient reporting cramps, in which in case they are together with CPK elevation, a temporary drug discontinuation can be considered.
Thank you very much. That's very interesting and very clear. So, from your perspective, in the landscape, the treatment landscape for patients with TGCT, how should systemic therapy be considered over surgery, and in what sequence?
So the use of systemic treatment for TGCT, also according to the label, is only for patients with locally advanced unresectable disease, or patient in which surgical resection could be related to high morbidity and in presence of symptoms. Unfortunately, we do not have so far any study to support the use of this kind of drug in the preoperative setting, and I really hope that we will be able all together to conduct this investigation in the near future.
Okay, that's very clear. Thank you, Sylvia. So, if we look at the systemic treatments, what is the knowledge, or what do we know about the impact on the recurrences or progressive disease after stopping systemic treatment?
The data we have are limited and are based on a phase 4 study of pexidartinib, where less than 20 patients were asked to discontinue the treatment, and based on those results, in patients that received pexidartinib for more than 5 years prior to discontinuation, we know that there is a risk of reprogression, but at least 50% of the patients were without progression at 2 years, meaning that at least in some cases we can probably have disease control that is prolonged even after treatment discontinuation. We also know that at the time of progression, re-challenge of the treatment corresponded to a new response. So overall, I believe that, again, we need a study to be able to provide good answer to this question, but treatment discontinuation and re-challenge is for sure a potential option. And now please answer this challenge question. And here is another challenge question. Now, Michael, let's turn to when to consider surgery versus systemic therapy in TGCT. We will illustrate these through two patient cases. So the first case is a 59 years old man that in the past was a very active guy with an history of diffuse TGCT affecting the knee. The history is very long with several prior surgery. And at a certain point, he had a recurrence that was cause for chronic symptoms, more than 3 years, a limitation of the function, and diffuse and edema. So, Michael, can we go together with you through the radiology of this case?
Yes, of course, Sylvia. What we see when we look at the MRI scan is that the complete inner side of the knee joint, everywhere in the front and in the back, is involved. There is diffuse synovial proliferation, multi-compartmental disease, and mostly also very large posterior compartment with a large Baker's cyst. Also, both cruciate ligaments and collateral ligaments are involved, and we can appreciate hemosiderin-rich lesions which are consistent with TGCT. If we look at the X-ray, it's not really bad yet, but we can already see some bone erosions, posterior medial femoral condyle, and in the retropatellar region.
And how would you manage this patient?
So, if we look at the outcome of repeat surgery, it's really associated with high morbidity and a high likelihood of residual and progressive disease. So, patients will have to have significant surgeries, facing a lot of rehab, pain, and also recurrences. Therefore, systemic treatment is preferred to reduce tumor burden and control disease. At present, vimseltinib is the only approved CSF1 inhibitor in Europe, which is available in some countries. Systemic first strategy is indicated because surgery is only reserved for patients with symptomatic disease that we can help with surgery. It's very important that a multidisciplinary team decides together with the patients on the primary treatment choice.
And Mikael, considering that this patient started being symptomatic when no active systemic treatment were available in Europe, how would you consider to treat this patient if you were without any drug?
So, if we look at the treatment of patients with a significant amount of disease, it's very difficult to get everything out. And therefore, it's very good that we now have the options in different treatment modalities. So in the beginning, he was not so symptomatic, so we should have waited a little bit longer before going to the first treatment. Then when he got more symptoms, at that time we only had surgery. Right now, maybe we would have considered systemic therapy, as the surgeons would have appreciated that this was not disease that was amenable to curative surgeries. And the surgery was also associated with high morbidity and long rehabilitation times. So upfront CSF1 inhibitors could have been a good first choice of treatment.
Thank you very much, Michael. Let's go through another case. This is a 45-year-old man with, again, a diagnosis of a diffuse type TGCT, again arising from the knee, which is the most common site for diffuse TGCT. This patient was suffering of chronic complaints due to the disease with a function limitation, pain, and swelling of the knee. Can you drive us through the readings of the radiologic images?
So if we first look at the MRI now, you see a completely different patient because although it's also diffuse disease, the disease is still restrained to the joint to the joint capsule. So it's not going outside of the joint and it's not in a Baker cyst in the posterior part. So we can see the hemosiderin again both in the anterior and posterior compartment and around the cruciate ligaments. But in this case, it could be resectable disease. If we look at the x-rays in this patient, there's only minimal cartilage damage and the joint is actually largely preserved. Ligaments and also the menisci are intact and there's no structural damage to the joint.
So, Mikhail, how does this case more in general influence your treatment decision?
So if we compare this case to the first one, we can now do an anterior and posterior approach to the knee, and we can do a complete synovectomy of the joint. Of course, in a complete synovectomy, it's very difficult to take out every part of the joint, but most of it can be removed. So in this case, it's feasible and with good likelihood of local control to resect all of the disease and not giving him too much morbidity. So systemic treatment is therefore not chosen to be the first option in this case, as the disease is resectable. A surgery-first strategy is mostly indicated in patients where the surgeons feel they can take everything out and therefore have a lower recurrence rate or a lower chance for progression.
Thank you, Mikhail. I believe that we are all very much excited that systemic drugs are eventually available for our patients, at least for adult patients, and we can treat them when surgery is not an option anymore. However, the message we want to send out is that surgery still remain the first standard approach to treat these patients, and for sure, these patients should be regularly seen by the orthopedic surgeon, also during their treatment with a systemic drug, as arthritis and other kind of complication can interfere also with the response to the treatment. So at the end, collaboration and multidisciplinary discussion and decision is the main strategy to treat TGC patients.
I think the last sentence is the most important one, as we are treating the patients and, of course, not the MRI or the symptoms. So it's very important to discuss the symptoms with the patient and the possibility of treating the symptoms with either a surgical or a systemic therapy. So if disease is resectable, while preserving the function of the joint, surgery remains the first option for most patients. But systemic therapy could be considered in patients with very extensive disease or already recurrent disease, where the chances of a cure for surgery are almost zero. And incorporating patient preferences, the impact of the disease on their quality of life, but more importantly, also the impact of the treatment on their quality of life, and finally, the treatment goals are all meant to be in the decision-making in the decision-making process with the patient and the experts in your hospital. And now, please answer this challenge question. And here is another challenge question. Thank you so much, Sylvia, for this engaging discussion on the management of patients with tenosynovial giant cell tumors. And thank all of you for watching.
This has been an activity published by Peer Voice.